My topic in this afternoon session is MRI of the hands and fingers. And let's see if my presentation shows up this time. Okay. Thank you. So we'll be talking about the MR imaging anatomy of the fingers in terms of extensor and flexor mechanisms. And we will also be talking about the data that the clinician wants in our MRI reports, especially on finger injuries. And we will also be describing some of the MR imaging findings in inflammatory and neoplastic conditions as well as the traumatic ones. So overall, we can talk about three different categories when it comes to the MR imaging of hands and fingers. And with traumatic conditions, they can be either acute or chronic in the form of overuse injuries or repetitive injury. One of the repetitive injuries actually is something that we almost all of us do. It's knuckle cracking, like this one here. I mean, cracking our knuckles. And it was a few years ago that it was shown to be, in a study done on an MR unit, that this cracking noise actually comes from, this sound actually comes from the instantaneous, almost instantaneous accumulation of gas within the joint, not due to the presence of gas there, which actually collapses, but rather the noise itself, the sound, comes from the accumulation, instantaneous accumulation of gas at one point that dissolves from the fluid within the joint. So this actually is a demonstration of this particular phenomenon. And right at this point here, at one point, as you can see, there is this accumulation of gas, which is almost, instantaneous, or which is almost spontaneous. It is not spontaneous, of course, because there is this dissolution of gas, which actually which actually coalesces into a bubble, and it is at this time that this sound actually occurs. So this was just for the fun of it, and this brings me to my first question, which is a 32-year-old male with hyperextension injury. A basketball hit the fingers in such a way that the fourth and fifth fingers were actually hyperextended. And my question here would be the location of the injury. Where do you think is the injury located? Is it extensor tendons, flexor tendons, or volar plates? So this image here is the fourth finger, and this one is the fifth finger. And if we can see the results, well, common sense makes us think that there would be some injury to the flexor tendons. However, if we go back to the image or to the presentation itself, this particular location here is the tear of the volar plate here in this fourth finger, and it is not only tear, not only avulsion, but also displacement or flipping of this volar plate here. Otherwise, the flexor tendons are okay. I mean, at least, partially they are seen to extend all the way to their insertions. This, however, and this here, they are abnormal. I mean, this particular location here tells me that there is this avulsion injury of the volar plate on the fourth finger, and also there is this flipping of the, or the displacement of the totally torn Waller plate more proximately. So normally, in microgravity, astronauts and cosmonauts and taikonauts have this posture. And this tells me that the fingers, as you can see here, if they are neutral, they would have this kind of like flexion attitude. And this is how it seems. I mean, she is apparently sleeping, and this is how the fingers would look like. So the flexor side somehow or somewhat takes over the extensor side, which is understandable because the fingers are meant to grip things. And if we examine the functional anatomy of the fingers on the extensor and flexor side, we will see that for the flexor side, which is now our subject, because of this hyperextension injury, there had been some tears of a structure that I have mentioned, and we will come to that. So there is this definition of flexor zones, which the hand surgeons use actually. The hand surgeons want to know about the injured zones, whether the injury is open or closed, and it is those questions here that we as radiologists are helpful to them. And it is not only with MRI, but also with plain films and ultrasound that we can help in some of them. And almost all of them also can be helped with ultrasound. But MR imaging is there on every one of them. So we have to know about the injured soft tissues. And with soft tissues, we need to know about some specialized structures of the fingers. And we will just come to Waller plates now. So this patient had Waller plate tears, and we will now see where the Waller plates are located. This is the metacarpophalangeal joint. This is the joint synovium. And just over it is the joint capsule. And just underneath it, you can see that there is this Waller plate that attaches to the proximal phalanx and also the metacarpal. And the same is also true for the proximal interphalangeal and distal interphalangeal joints. This is how they look like. They have this complete attachment to the distal aspect of the joint, and then some partial attachment, as you can see here, like a horseshoe, to the proximal aspect. But on the distal side, you can see the attachment should be complete. So this is how it looks like. If this is removed, the flexor tendon, you can see that there is this collagen-containing structure, which is torn on this patient here. And coming back to these images here, you can see that there is this avulsion here. And if there is avulsion, the hand surgeon also wants to know whether there is osseous avulsion or non-osseous avulsion. And if we can figure this out with MRI, that's fine. However, most of the time, we will also have plain films that will help us. And on this patient, there was this non-osseous avulsion here on the fourth finger. Ultrasound is also quite useful. For this fifth finger injury, from this particular level, this is the flexor tendon. This is superficial, this is deep, this is the bone. This is the normal third finger. And this is from my institution. We did this ultrasound, and you can see that the flexor tendon is here. The Waller plate is here, in between the bone and the flexor tendon. But it is lacking here, because it is no longer there at this level here. It should normally be there. It has flipped more proximally. And these are the sagittal images. You can see that this is in the normal location here, but this is no more in the normal location, and it has slipped somewhat proximally. And if I just turn the images to match this one here, you can see that it is no longer there in its normal location as on this particular finger here, but it has slipped, actually flipped more proximally. So on this particular patient, in an ideal world, we should talk about the zone of the injury, as well as the avulsion, the presence of avulsion, whether it is osseous or not, and whether there is any retraction or not. So we should tell them that there is this 1 centimeter proximal flipping of this torn Waller plate on this fifth finger. So this brings me to my second question, which is the case of a 54-year-old lady who injured her hand while trying to catch a falling glass object 3 weeks earlier. Just when she tried to catch a vase apparently she hit her hand, and then there had been this injury. So what do you think is the injury here? Those are axial proton density fat saturated images. Do we have a transaction of the extensor tendon? Do we have a tear of the sagittal band or a tear of the flexor tendons? Perhaps we can see the answers now. Most had it correct. If we can go back to the presentation. So this is a tear of the sagittal band. The sagittal band is a structure that we will look at more detail now. And you can see that there is this partial tear of the sagittal band here and here also. There is not a complete transaction of the extensor tendon here, but rather the tear of the sagittal band on this radial side right here. The flexor tendons are okay. And with the extensor side of the hand, we also have these extensor zones. And once again, we are able to tell or help the hand surgeons in many ways. And we once again need to know about the injured soft tissues. So the sagittal band is a structure which actually has some role, as I will show you momentarily, in the hyperextension of the fingers. So this is the volar plate. Once again, we have seen that. And you can see that we have these collateral ligaments here, the primary one and the accessory one. So the collateral ligaments are those structures here. They are somewhat deeper, not those structures surrounding here, but rather those deeper structures. And these are the extensor, these are the sagittal bands of the extensor mechanism. They are more superficial, and they are more superficially located to the collateral ligaments. So the sagittal band has this role in hyperextension. Normally, it is relaxed in neutral position, but during hyperextension, it restricts the proximal movement or proximal excursion of the extensor tendon. So if there is injury here in the sagittal band, there is the risk of further injury to the extensor tendon. So if we go back to the presentation, we will see that in this patient, there was the risk of slippage of the extensor tendon more proximally because of the torn or partially torn sagittal band. Unfortunately, I do not see the presentation here and there, so I will need to look at along with you. I'm going to need to look at there. So you see that there is this injury to the sagittal band, highlighted also on the left on the coronal images. So in this third patient here, this is not a question, obviously. There is this extensor tendon transaction in this particular location here. There is this complete tear of the extensor tendon, but it still remains within the tendon sheath. So there had been some proximal retraction of the tendon, that's for sure. And then there is some edema of the sagittal bands on both sides. But otherwise, what happened here is the transaction of the extensor tendon with the proximal retraction of about like 1 centimeter. This patient here is a young man who injured his middle finger while carrying luggage. Sometimes we do this, you know. Sometimes we kind of like overdo ourselves, and then we tend to pick up things in ways that we should not actually be doing. And then this young guy apparently tried to lift a heavy luggage with the third finger. And the injury here actually has to do, those are the flexor tendons. Those are superficial to the volar plates. And I have shown you the tendon sheets there. And then more superficially, we have the so-called pulleys. So the pulleys are structures that actually restrict the motion of the flexor tendons more anterior or more superficially. And they have this role of kind of containing the flexor tendons, but still allowing them to move like in a fishing hook here, like a pulley mechanism. And then they have this role, especially during activities like climbing, where the fingers are really, really strained. And if they are injured, we will be able to see them on MRI. And then their nomenclature has to do with their shapes. They are annular or cruciate, as shown here. And then the numbering of them is such that it increases from the proximal to the distal. So depending on how you have your axial sections, you can see some of them, not all of them, in a single section. Wherever it crosses, it will depend on the crossing area of the section. And sometimes you can even make them out on sagittal images as those kind of small, thin structures here. So giving IV contrast was shown to better display the injuries of pulleys. And if we go back to the patient that I have shown you, we will see that there is this edema of the pulleys there. And in this particular patient, it was grade 1, so there was no need for surgery. Only on the higher grades, we will need, the patient may need the surgery. Otherwise, there will be a splinting of the fingers. And going back to this case, we have the pulley strain at A2 to A5 levels. And in between, actually, the cruciates are also edematous. But once again, what is injured here is the pulley mechanism of the fingers. You can appreciate that we actually do not have much of tenosynovitis there. And more distally, there is some tendon sheath fluid here, because apparently there is some restriction of the motion of the fluid there. But otherwise, there was not much of tenosynovitis, but rather some surrounding soft tissue edema in the form of pulley strain. So this patient actually is a dentist, and his hand apparently hit the patient's teeth. I don't know what happened to the patient's teeth, but what happened to his hand was apparently some injury at this dorsal side right here. You can see that there is contrast enhancement there. There is cellulitis. And such injuries carry the risk of infection, as you know, because there is this possibility of contamination through some skin laceration there. But the point I'm trying to make here is, since he is a dentist, it is not very surprising to see some enhancement of these lumbrical muscles here, right here. Because this patient actually, being a dentist, makes a lot of use of the lumbrical muscles. So this is kind of an overuse appearance, not necessarily an overuse injury, but overuse appearance, this contrast enhancement in these muscles here. Because this was something that we were not actually expecting. We were expecting whatever happened on the dorsal side. And this is an example of an overuse injury, if you will, because this is the extensor mechanism of the fingers, and the extensor mechanism is an extensive structure that goes all the way to the elbow. So the finger extensor mechanism is not restricted to these tendons here, but their muscles also all the way to the elbow. And we have the extrinsic and intrinsic muscles of the extensor mechanism. And as you can see here, the lumbrical muscles, as well as the interosseous muscles, are portion of the extensor mechanism. Whatever is highlighted on green on these images show you that they are active. They are actually actively used. And you can see that during extension, there is the activity of the lumbrical muscles as shown here, right here. So although they are on the flexor side, the lumbrical muscles actually have a lot of role during extension. And this is why this particular dentist patient had this kind of enhancement here because of the overuse of the lumbrical muscles. So the exact condition, the acute condition was this here, some cellulitis dorsally, but then apparently he also overused his lumbrical muscles because of all this contraction and extension of the fingers. Those are the extensor tendons, and then there is the so-called extensor hood, part of which is the sagittal band here, and then we also have some slips here of the extensor tendons. All of them actually make up the so-called extensor hood, and then we have the flexor side with the flexor digitorum profundus and also the flexor digitorum superficialis here. So there is this so-called Leddy-Pecker classification of FDP avulsion injuries, because the FDP injuries are what really counts in terms of hand surgeons. And it is, it's a good idea to be familiar with this classification here when it comes to the grading of the injury there, because this is the injury, this is the grading that they use in terms of having the patients into surgery. When there is avulsion here, as shown here in this lateral radiograph, this automatically makes it to the bony fragment grading to either type 3 or type 4. And then this particular patient actually was operated on without any need for MRI apparently, because this was an acute condition. And then just by ultrasound, it was shown that the tendon still attached to the bone. So after surgery, they reattached the avulsed bone to its place. This patient, on the other hand, had this fifth metacarpal fracture. And at the time of injury, during the orthopedic maneuvers that they did, apparently there was some iatrogenic injury to the fifth finger, to the fifth flexor tendons here. So after a while, the patient comes back, and then apparently he cannot flex the fifth finger. So what happened was, there was this retraction of the fifth FDP, and you can see that it has actually flipped on its back, because at the time of the injury, there was some partial tear of the flexor tendon, and then after a while, during the reduction of the fracture, apparently more injury ensued, and then over time, part of the flexor tendon retracted more proximally. So we have to tell them how much of a retraction there is, and you can see that actually at the time of the injury, there was also some tear of the flexor tendon, but then it had retracted more and more with the maneuvers that the orthopedic surgeons did. So there is also some avulsion at the distalmost aspect, as also shown here, right here. We need to take a careful look at the bones, especially on T1 weighted sequences without any fat suppression. So this is a patient with pain at the dorsal radial aspect of the wrist, and those are the images. This patient apparently had extensor tenosynovitis. She also has the so-called distal intersection tenosynovitis, as depicted right here. Those tendons show you the intersection of two tendons here, and how the synovial sheets of the tendons are also inflamed here. This is actually a less common condition than its proximal counterpart, but it was described some years ago, and we are seeing more and more of this. The distal extensor intersection actually has these two intersections. One of these tendons here, abductor pollicis longus and extensor pollicis brevis, with extensor carpi radialis longus and brevis. And more distally, we have these tendons here, extensor pollicis longus and the same two right here. So this actually is becoming more and more frequently seen because of the overuse of the thumb in the last several decades with all these smartphones and tablets and everything. Apparently, there was this condition described as Nintendonitis back in 1990s, as early as 1990, as you can see here, because of the overuse of Nintendo toys at that time. And such injuries like a V fracture was also described. And then later, this triad of conditions, along with V-itis. And then more recently, the so-called Vetsepitis, because of the frequent use of extensor tendons of the thumb. So as you can see, it is described here. The patient was on duty Christmas Eve, and then the following day apparently had to respond to a lot of messages. So this condition of Vetsepitis ensued. This patient that I have shown you had this extensor tenosynovitis, but apart from regular homework, there was no mention of something like Vetsepitis. So it is not only related to the use of smartphones or tablets. Sometimes we can see it in conditions where extensive use of thumbs during home or housework is concerned. One of the most characteristic injuries to the fingers, as you know, is the ulnar collateral ligament of the first MCP joint, which is also known as Stenner's lesion or skier's thumb. There is this ulnar collateral ligament tear, and as you know, what happens here is the interposition of the adductor muscle, aponeurosis, at the ulnar site underneath the torn ulnar collateral ligament. In other words, when the collateral ligament is torn, it is this blue structure here. If the adductor aponeurosis is interposed in between this and the finger itself, there is no way this torn structure can go back to its location without surgery. This is why it is called a surgical condition, and these patients would have the increased extension or radial deviation of their fingers during maneuvering, and the aponeurosis had to be taken out of its place, and then the collateral ligament should need to be reinserted to its location. Those lesions, the Stenner-like lesions, they are called Stenner-like lesions. They are interposition injuries. They are also described elsewhere. They are being more and more described, and the same nomenclature is used, like Stenner-like lesion. I know this is about fingers, but you can see that in our patient, in this patient of ours, where there is this MCL full thickness tear, there is this interposition of the torn ligament, more distally, in between the meniscus and the tibia. And if it is not taken away, there is no way this would heal by itself. So they are considered to be surgical conditions. And this can well be misinterpreted as displaced meniscal tears on sagittal images. Of course, they can also be interposed into the physial line here or into a fracture line as shown here. So they are also called Stenner-like lesions. And they are seen with the distal MCL high-grade tear. So Stenner, the name Stenner is also being more and more used in terms of interposition injuries. There is also the possibility of the radial collateral ligament tears as shown here. And when this happens, there is this increased laxity of the finger to the ulnar side as opposed to the radial side with the Stenner lesion. This patient had tuberculosis with atypical mycobacteria. He was a farmer. And you can see that there is this extensive bursitis here on the volar aspect of the hand and also the wrist, also the distal aspect of the forearm. And you can see that there are those structures here which are actually, as you know, rice bodies. Those rice bodies actually denote the presence of necrotic synovium. The synovial debris finds its way to coalesce like this into these so-called rice bodies because they apparently look similar to rice. And it is interesting to note that with T1 weighted images, without any contrast, they are usually not visible. But it is with fluid sensitive sequences that they are seen. And in this patient here, we also have the so-called horseshoe abscess, which actually has to do with this Parona's space here, which is the site of potential communication with the ulnar-sided bursa and the radial-sided bursa. So these structures here are not called tenosynovium, but rather bursa, ulnar bursa or radial bursa. And it is at this site that these two structures actually communicate, and then there could be the appearance of this so-called horseshoe abscess. Otherwise, rice bodies can be seen in some other conditions as listed here, like rheumatoid or inflammatory arthritis, psoriatic arthritis, degenerative conditions like osteoarthritis, and also neuropathic arthropathy. And this particular patient was interesting in that those bodies were smaller, like about 80 days earlier, almost 3 months ago. And then over time, apparently they coalesced. And without any intervention, it is possible that rice bodies may altogether disappear. So with no drainage or with no surgical intervention, just by triple anti-TB treatment, this patient had his rice bodies completely disappear. So it is possible that they can disappear without any intervention other than anti-TB treatment as in this patient. Juvenile idiopathic arthritis is a condition whereby you can only have tenosynovitis in the hands. So it is not necessarily associated with the presence of erosions or even synovitis. When you see extensive tenosynovitis in a patient or scattered tenosynovitis, there is always the possibility of inflammatory arthritis, even if the joints look perfectly normal. So synovitis, the joint synovitis, need not be the part of the picture. Whenever you see scattered or extensive tenosynovitis in the hands, the mention of an inflammatory arthritis like juvenile idiopathic arthritis or rheumatoid arthritis need to be made, because it is not always that you would see the involvement of the joints. So in this patient, apparently there are these erosions, but once again, this is another patient. Once again, you don't always need to see such conditions as joint synovitis or erosions. Sometimes you can only see tenosynovitis. This is how we have the imaging of the both hands. Usually we do this in this like prayer position, like this here. The patient goes into the magnet like this. Or we can have the patient lying in this so-called Superman position and have both hands imaged like this here. But it is important to put a marker there because of the changes of the orientation in the images. We advise our technicians to put some marker to show us the right side. So we are in agreement with them that the MR imaging marker would show the right side. So this is how it can also be obtained with both hands side by side. But as you imagine, if you can have the hands on prayer position, there is even a more decrease in the imaging volume, so you can have a more detailed imaging with the prayer position rather than this Superman position, if you will, like this here. Okay, this brings me to my next question, and I don't know if we have put this in the system, but if you look at the images here, what would be your diagnosis? This is a 29-year-old lady with hand pain at the region of the MCPs. This is how the lesions look like on MRI. And this is the other hand. So do we have rheumatoid arthritis? Do we have pseudogout or psoriatic arthritis or Kienberg's disease or Dietrich disease? So apparently the condition involves the MCP joints. The patient did not have SLE, systemic lupus erythematosus. There was no use of corticosteroids. If we can go back to the presentation. So with rheumatoid arthritis, we would appreciate the presence of some periarticular osteopenia, which is lacking. The PIP joints are normal. Even the distal aspects of the MCP joints are normal. But then we have this condition called Dietrich disease, which is quite a rare instance actually, but still, with radiology, we are in a position to really make the diagnosis. And in this patient here, there was no history of SLE, no history of corticosteroid use, no rheumatoid arthritis, and it is the avascular necrosis involving a metacarpal head. Usually, it involves the long metacarpals, like the second and third. Our patient was interested in that all the metacarpals, including the first ones on both sides, although to a lesser degree, they were all involved. And this could well be idiopathic or traumatic. Apparently, this patient had this condition in an idiopathic way. So once again, the distal aspects of the MCP joints are fine, no joint effusion, PIP joints are okay, and apparently we have the avascular necrosis and the ensuing irregularities and resorptions and the somewhat distracted appearance of the metacarpal heads. And those are the plain film. These are the plain films. Another condition that we can see in a patient with chronic dorsal pain in both hands would have this particular condition that we call os styloideum, or the variant bone of os styloideum, which is also known as carpal boss. This patient had this condition on both sides, as you can see here. This is the other hand. And you can see that there is this subcortical edema-like appearance just underneath the cortical borders there. And those are the coronal images. You can see that there is this bony excrescence. Otherwise, other bones are normal. I mean, there is not extensive degeneration, but at this particular location, because of the presence of os styloideum, which is a variant bone, this patient had this condition, which is called carpal boss. Carpal boss may be associated with os styloideum, but then it may sometimes be even without os styloideum, because this particular bone here may be partially fused with the other bones surrounding it. So the patients would usually have pain and limited range of motion. One thing that is important to know is there could be overlying ganglion or bursitis. As you know, whenever we see ganglia in the musculoskeletal system, we are reminded that there had been some strain, there had been some overuse of this particular joint there. And in this particular patient here, the presence of ganglia would be exemplary of the strain placed on the surrounding soft tissues. That patient did not have it, but this patient here has the tenosynovitis and some tendon tears of the extensor side here. She had, this is a different patient, she had carpal boss also on this side right here. So overlying extensor tenosynovitis would be an important consideration there. Here's another patient. This brings me to another condition with enlarged fingers, an 8-year-old female. And this is quite straightforward in that when we have enlarged fingers with the association of fibrolipohamartoma of the nerve at this particular finger or toe, if you will. This is also possible in the feet of patients. Then this is called macrodystrophia lipomatosa. So we have this spaghetti-like appearance of the median nerve with interposition of the fat tissue there. And those were how the hands look like. Actually, this is quite a straightforward diagnosis for the clinician, but sometimes it is necessary to show the extension or the extent of the involvement of the nerve there. Of course, we can have lipomas in the hand. Usually they are located at the palmar side. They can be intramuscular as shown here, or they can be still on the palmar side, but subaponeurotically located right here. This is somewhat different from true tendon sheath lipomas, which are quite rare. With true tendon sheath lipomas, the lipoma would surround the tendon all the way, with the exception of the mesotendon right here. But this patient, as you can see here, it has this interdigitation of the lipoma rather than complete surrounding of the tendon sheaths. So this was not a tendon sheath lipoma, but rather subaponeurotic lipoma. This is the aponeurosis here. But this is still quite difficult for the surgeon to kind of excise without really bothering the flexor tendons. We can also have fibromas of the tendon sheath, as shown here. As you know, characteristically, they have this low signal intensity both on T1 weighted and also the T2 weighted sequences. Whenever there is enhancement and whenever there is some high signal there, it shows the activity of the lesion, some increased mitotic activity at this particular location, but otherwise it is quite straightforward. Another straightforward condition where MR would help in terms of showing the extent of the fibrotic bands here would be the so-called Dupuytren contractures or palmar fibromatosis, which usually involves the fourth or fifth fingers. And usually those patients are elderly. The fourth ray involvement is typical as shown here. And it is those fibrous bands that need to be taken care of, sometimes excised by the surgeon. It is not always possible to make the diagnosis of soft tissue lesions in the hand. All we can say about this particular web space located lesion would be its size and its extent. Apparently, it extends both to the dorsum and also the palmar side of the hand. And it is not always possible to make a suggestion of this condition, which was the pathological diagnosis. As you know, the well-contained appearance of soft tissue tumors is not necessarily something to do with benignity of the lesions. Quite malignant lesions may well have quite distinctive borders. So, in somewhat contradistinction to bone tumors, as we have seen now, you don't need to have a wide zone of transition with the soft tissue lesions. This could well be some malignant lesion also, but apparently the pathological diagnosis was angioleiomyoma. With the hands, one of the most common lesions would be the giant cell tumor of the tendon sheath or tenosynovial giant cell tumor, the new or the most current name. And as you know, their T2 characteristics are such that they are not usually of a very high intensity like a fluid, but rather somewhat subdued intensity. They usually, if not always, enhance quite profusely with contrast, as shown here. And then about 10 to 20% of cases would show some pressure erosions adjacent on the adjacent bones. They are usually on the flexor side, and they are usually seen on between the third and the fifth decades. Common things being common, in the hands and the fingers, as well as the wrist, the most common soft tissue lesion would be ganglia. Actually, it is the #1 soft tissue lesion all across the body. When it comes to the musculoskeletal system, #1 soft tissue lesion would be ganglia, most likely followed by lipomas. This is also true with the hand, and then sometimes they can be seen with the tendon sheaths. So you can see here that this ganglion actually involves the tendon sheath, and then you can see the mesotendon here, right here, stretched by the presence of ganglion there. They can be smaller, as shown here. They would not enhance normally with IV contrast. Of course, the most common, or one of the more common lesions in the fingers would be the so-called glomus tumor. And as you know, the characteristic of the lesion would be the profuse enhancement and some bone erosion at the dorsal aspect of the distal fingers, aspect of the fingers. And this is how the glomus body actually functions. As you know, they are actually thermoregulators of these arteriovenous anastomosis at the fingertips. They close the anastomosis during cold times, and when it is hot, they would actually allow the anastomosis to operate, kind of acting like a thermoregulator. This is quite characteristic in terms of the location of the glomus tumors. However, look at this particular patient here. This is also the location of the glomus body, but then this patient actually had a subungual epidermal inclusion cyst. I have not shown you the contrast enhanced ones, but if there were contrast administered, there could be heterogeneous enhancement or peripheral enhancement of the lesion, depending on the chronicity of the lesion. And then those actually are proliferation of epidermal cells. They are benign cystic lesions, and then there may be some central debris as shown in this patient here. This brings me, I guess, to the last one. This is a patient with squamous cell carcinoma. Squamous cell carcinoma is the #1 malignant soft tissue lesion in the hands, and characteristically, the skin would be involved, and then some of the subcutaneous tissue. So it is important to realize that whenever skin involvement is present in a lesion, in a solid lesion, there is this possibility of squamous cell carcinoma, which is the #1 malignant lesion of the hands and fingers. This brings me to the end of my lecture, and I really thank you for your attention and for the invitation. Thank you.
Thank you very much for this nice presentation.
Thank you.
¿Alguna pregunta, alguna duda? Bueno, vamos a el café y a las 4:30 venimos para la última charla de acuerdo con el programa. Muchas gracias.